Hello and welcome to my presentation on the approach to shock. My name's Tom Gleeson-Hammerton. I'm a student at the Graduate Diploma of Paramedicine Critical Care in Charles Sturt University, and this is a presentation for the Advanced Medical Care topic where the lecturers have said, how about you come up with a lecture and do some presentations for a change? So we thought, why not? So today's presentation, we're going to go over an outline quickly what shock is, what the different types of shock are, and then we're going to go and discuss the epidemiology, the pathophysiology, the assessment, the management of some of these subtypes of shock. And then there's finally going to be a little bit of references at the end, so you know I'm not making stuff up. So grab your popcorn, sit back and enjoy the presentation. Hopefully there's some funny moments in there, and I've tried to focus on stuff that I've learnt in the process of making this, and stuff that I feel will improve my clinical practice as a paramedic already. You often hear as paramedics on the road, especially when you go to a vehicle collision or something like that, where bystanders will say, I just think they're in shock. It's definitely not that. There's a difference between what the layman thinks is shock and what we describe as shock. So they're often not perceived as being as bad as the reality of medical shock. So there's no such thing as someone who's just in shock. So what is real shock then? So it can be defined as a state of circulatory insufficiency that creates an imbalance between tissue oxygen supply or delivery and oxygen demand or consumption, resulting in end organ dysfunction. So it's quite an open-ended definition that has many causes, and these causes have different signs and symptoms, but hypotension and hence insufficient tissue oxygen supply is common to all of them. So what is meant by circulatory insufficiency? So if we look at it in its simplest form, oxygen delivery to the tissue is dependent on blood pressure. And that's assuming that oxygenation and gas exchange isn't impaired. So everything else is working fine. Oxygen can only get to the tissue that it needs to perfuse because of blood pressure. And blood pressure is made up of the following formula, where the mean arterial pressure is equal to the cardiac output multiplied by the systemic vascular resistance. Now, cardiac output itself exists as heart rate multiplied by the stroke volume, where the stroke volume is the amount of blood ejected from the ventricles of the heart. Both ventricles are roughly the same. The left is slightly more than the right, but we typically only really care about left ventricular stroke volume in terms of global cardiac output. So as we know, any failure in either cardiac output or systemic vascular resistance will result in compensation from the one that isn't failing. So if we have a decrease in systemic vascular resistance, it will result in a compensatory increase in cardiac output. And likewise, the cardiac output formula itself will try and do the same thing. Where if there's a loss in stroke volume, you'll increase heart rate to try and compensate. So what are the different types of shock? There's four main different types overall, but often some of these are a bit blurry and can kind of spill into one another. And they each have specific causes, the first of which is hypovolemic shock. We then have distributive shock, obstructive shock, and cardiogenic shock. So this presentation is only going to be an overview and go into one or two of the different subtypes of these shock states, as we don't have enough time to go through every single part of shock and every single pathophysiological process underlying all of these four types of shock. First one that we're going to start off with is hypovolemic shock. Hypovolemic shock occurs when there's a loss of actual volume. Sometimes you can hear it referred to as absolute shock or absolute volume loss, which impacts cardiac output, specifically the stroke volume. And the volume loss can either be blood or plasma or both. The main cause of blood loss is obviously hemorrhage, and that can either be trauma or medical as the cause of the hemorrhage. And less frequently, hypovolemic shock is caused by plasma loss, and that's where you would expect to see it as a result of gastrointestinal issues like vomiting and diarrhea, or dermatological like heat stroke and burns, renal pathologies like osmotic diuresis, or sodium losing nephropathies, or interstitial extravasation or third space losses such as a crush injury or severe pancreatitis. Distributive shock is where you have a maldistribution of volume, not loss. So we haven't actually lost any volume, it's just not in the right spaces. Profound vasodilation, hence why sometimes distributive shock can be called vasodilatory shock, results in decreased pressure because we're losing that systemic vascular resistance. There's many causes and subtypes. Sepsis is probably one of the main big ones that everyone's pretty aware of, and that can cause septic shock. The next is anaphylactic shock. You also have neurogenic shock, drug or toxin induced, such as narcotics, envenomation, or transfusion reactions. And you can also have endocrine induced distributive shock, especially things like the Addisonian crisis or hypothyroidism. Obstructive shock refers to any kind of physical impedance on the heart's ability to pump due to extracardiac causes. So that means anything that's physically restricting the heart's ability to work, but it's stuff that is occurring outside of the heart. So we have an obstructive shock state that impacts cardiac output, specifically stroke volume, but not because of a lack of volume, but due to the decreased preload and hence a decreased force of contraction if we look back at the Frank-Starling law, for example. It can also be due to an increased afterload, where the increased pressure that the left ventricle has to overcome on the ejection of blood can result in less blood being ejected. Often, it's both impacting on preload and afterload. Causes can either be pulmonary vascular or mechanical in nature. Cardiogenic shock is where you have impaired cardiac output due to intracardiac causes of pump failure. And these, so cardiogenic and obstructive, do have some pathologies which some people put under one category and some people put under the other category. This is probably the main one where you get a bit of blurring, but you often see issues or pathologies within the heart itself that are leading to pump failure, and this can impact both heart rate and stroke volume. And the causes for this can be cardiomyopathic, dysrhythmic, or mechanical in nature. And this picture in the background is a picture of a severe cardiomyopathy as well. You can see a very, very thick left ventricle there, as well as lots of tissue formation inside the ventricle. So let's start with hemorrhagic hypovolemic shock. The epidemiology of hemorrhagic shock is interesting. You get it's the leading cause of shock and trauma, and it's the second highest cause of death in trauma patients after head injuries. Bleeding in trauma is most likely to be seen in the 20 to 24-year-old age group, but typically, people less than 40 or so are the main demographic seen in traumatic bleeding. And most massive transfusion packs are used for traumatic hemorrhages. While elderly people aren't usually seen in the most affected demographics, they are more likely to die than younger people due to less physiological reserve, and also because many of them are on anticoagulant or antiplatelet medication, which impairs the body's ability to stop bleeding. So, as one of my favourite scenes from Monty Python, what are you going to do, bleed on me? So the pathophysiology of hemorrhagic shock. The most common cause is trauma, but medical bleeding is pretty common too. And as paramedics, we're especially probably likely to see medical bleeding in a gastrointestinal or obstetric situation. Regardless of the cause, whether it's trauma or medical, severe hemorrhage leads to decreased blood volume and hence a decreased stroke volume, which means that the blood pressure and oxygen and carbon dioxide carrying capacity is impacted. And this results in hypoxia, which results in the lethal triad of acidosis, coagulopathy, and hypothermia. Into this in a little bit more detail now. And as you can see, there's a nice graph here image here from Rishi MD on Twitter that kind of explains the lethal triad. So when we have a hemorrhage, especially a severe hemorrhage, we'll have an initial compensation, which is usually an increase in heart rate and the contractility of the heart, and we'll also see some arteriovenous constriction, and then we'll see platelet plugging, fibrin mesh formation, all of those hemostatic agents coming into play. But as bleeding continues, we start to develop tissue hypoxia, and hypoxia, if it's sustained, will then make cells turn to anaerobic metabolism for their energy source, and the result of sustained anaerobic metabolism is a metabolic acidosis. Now, a prolonged acidosis of less than 7.2, which is a reasonable derangement considering the body likes a narrow range between 7.35 and 7.45 for the pH, can result in impaired clotting and left ventricular dysfunction as well. And then that leads to a coagulopathy, where the clotting factors become less effective, and the enzymes that also produce the clotting factors don't work as well either. So our ability to clot is impaired, and the body's ability to generate those clotting factors is also impaired, making the body's attempt at hemostasis is impaired in general. So the end result of the sustained hypoperfusion plus the sustained hypoxia plus the anaerobic metabolism is hypothermia. And hypothermia occurs due to the decreased cellular function, where when cells are moving to anaerobic metabolism, they generate less heat as a byproduct. And the result of hypothermia is that we start to go down a death spiral, and it also starts to worsen some of the enzyme factors and clotting factors as well. Hypothermia itself can be worsened by environmental or iatrogenic factors. So if we consider a patient who's been stuck on a cold road or a floor and they're bleeding, they have an environmental exposure which will reduce their heat, or increase heat loss rather. But then we as paramedics come along and we expose the patient for a secondary survey, as we should, to be able to thoroughly see if there's any injuries that we haven't identified. And we may even give them some fluids to try and improve their blood pressure. But both of those interventions will also result in further heat loss. So this is a vicious self-perpetuating cycle that leads into a death spiral, and hence it's known as the lethal triad. So what can we do to manage or assess first hypovolemic shock? So bleeding is going to be internal or external, obviously, and both are difficult to quantify, and it's very difficult to just look at a volume of blood spread out over the ground and accurately say how much blood is lost. So we should consider hemorrhagic shock if we have a heart rate above 110 beats a minute, and we have a systolic blood pressure of less than 100 in a patient that's either got an obvious or suspected major hemorrhage that can be internal or external. Now, this may require some conjecture in the pre-hospital setting. Not all patients are going to be obviously bleeding, especially those that have got internal blood loss. So if it's available and it's appropriate, consider an EFAR scan or a focused assessment with sonography and trauma to try and identify any free fluid in the abdomen and any other traumatic pathologies as well. So how are we going to manage a patient that we suspect or we know is sustaining significant blood loss? We previously had the Dr. ABC approach, or the ABC airway breathing circulation approach, and while this works in most cases, really it doesn't address the risk for this patient in the correct order. And so that's why we'd suggest to follow MARCH or the circulation airway breathing approach. MARCH stands for massive hemorrhage, so control massive hemorrhage first, then support the airway as appropriate, support and secure the airway. Respiratory support, which can be providing oxygen or relieving any tension pneumothoraces. Circulatory support, which would be the introduction of fluids or blood products. And hypothermia should be prevented as a matter of urgency as well. So if we come back to that in more general terms, we need to stop the bleed by any means necessary. The most important would be direct pressure if possible, but if you're unable to stop it and if life-threatening bleeding is still occurring, use an arterial tourniquet. There's no issue with that, and make sure it's a good arterial tourniquet with a windlass. Also, pelvic binders are significantly effective for reducing blood loss into the pelvis in the case of a traumatic bleed. We want to minimize the use of crystalloids historically, we've tried to correct significant hypotension and hypovolemia by smashing in cold fluids. There's a number of reasons that we don't want to do that. Like we discussed, it helps worsen hypothermia because the fluid is cooler than body temperature. But we've also found that crystalloid administration greater than about 1.5 to 2 litres is associated with an increased risk of mortality due to the hypothermia, but also because of a dilutional coagulopathy. Also, crystalloids don't have any oxygen carrying capacity, so whilst it's expanding volume, it's not expanding your actual perfusion. So with that in mind, we want to tolerate permissive hypotension, which is the theory that the best clot that the patient generates on their own is the first clot that they make. And as a result, we want to allow a mean arterial pressure of about 85 to 90 millimeters of mercury. When it does come to volume replacement, it's preferred that we use blood products, especially in a 1-to-1 ratio, 1-to-1-to-1 ratio rather, of red cells, fresh frozen plasma or platelets. Obviously, that has complexity in the pre-hospital setting. Most retrieval services are only running with packed red cells at the moment. In that case, that's still better to use than excessive amounts of crystalloids. Another medication to consider, and this again is suitable in traumatic and medical bleeds, is a medication called tranexamic acid, which should be administered within the first hour preferably, because it has considerable mortality benefits, but it shouldn't be administered any longer than 3 hours after the onset of bleeding. Having said that, whilst it helps reduce further bleeding, it can give the impression that the problem is fixed if this is administered. A good way to view tranexamic acid is that it shouldn't be prioritized over stopping the bleeding, but it does stop bleeding from getting worse because it prevents the breakdown of clots by interfering with the breakdown of fibrin in the fibrin mesh. Finally, we need to transport to definitive care. So transport to a facility that can manage the cause of bleeding. So obviously if it's a trauma, we need to transport to a major trauma centre, and that's been shown in the UK to improve patient outcomes considerably by getting them to do definitive care sooner. But if we consider medical causes, if you've got a patient whom we suspect is having a ruptured AAA, for example, we'd want to go to a facility that has vascular surgery. Or we'd want to transport a patient that can facilitate catheter embolization if we suspect they've got a severe gastrointestinal bleed, for example. So moving on to some distributive shock pathologies now, we're going to look at sepsis first of all. And sepsis is an area that's undergone a lot of change and a lot of revision in recent times. So the epidemiology, sepsis is a big problem. And there's conservative estimates that there's about 30 million cases a year worldwide, with about 6 million deaths. So in Australia, we have about just under 16,000 cases a year with about 5,000 deaths, which is actually more than the national road toll. And we put a lot of emphasis on the national road toll, and yet a condition which is affecting nearly 16,000 people a year and is killing 5,000 doesn't get as much public attention. The incidence of it is increasing in Australia, so the incidence of septic diagnoses are increasing in Australia, and but it's especially bad in third world countries, obviously, where infection control and access to healthcare is worse. And septic shock is thought to be responsible for around 1/3 to 50% of in-hospital deaths in the USA. It's such a big problem that the WHO, no, not these guys have passed a resolution recently to improve the worldwide prevention, diagnosis and clinical management of sepsis. Let's talk about the pathophysiology of septic shock. So sepsis occurs when an infection from bacteria, such as the Staphylococcus aureus here it's on your screen, which is a very common cause of bacterial infection, or even fungi and viruses, can cause a dysregulated host immune response. That host immune response is helped along by inflammatory mediators, And there's lots of those to name, but some of the big ones would be tumor necrosis factor alpha, your various interleukins, interferon, and other cytokines that kick in as part of the immune response. There's also the activation of the complement system, and this can be activated by the classical antigen or antibody, classical antigen-antibody reaction, or even the alternative activation pathway, which is as a result of endotoxins from bacterial cell walls. The complement system assists the immune response by encouraging phagocytosis, which is the engulfing of foreign pathogens by white blood cells, as well as bacterial cell lysis itself, so the breakdown of bacterial walls and the destruction of the cell. And it also activates mast cells as well, which is responsible for further release of inflammatory mediators such as histamine and serotonin. Now, the classic antigen-antibody response, or the alternative endotoxin response, and the activation of the complement system results in organ dysfunction due to poor perfusion. And that's because the inflammatory mediators themselves activate the nitric oxide synthase enzymes. And NOS enzymes result in increased nitric oxide, and that causes an increase in vasodilation and subsequent loss of blood pressure. So that, going back to the formula, is a loss of systemic vascular resistance. Anaerobic metabolism is thought to occur as well, but this is a controversial area, and I'll explain why in a minute. There's someone who we suspect is having or is experiencing septic shock. So the definitive diagnosis in the pre-hospital setting is quite difficult without labs and further investigatory interventions or assessment techniques. It's important to note that there's a difference between sepsis and septic shock. Sepsis is the condition that causes septic shock, and the onset of sepsis is marked by the beginning of any organ dysfunction that is remote from the site of infection. Septic shock is a subset of sepsis with profound systemic circulatory collapse, enough to substantially increase the mortality. And this is going to be seen with severe refractory hypotension that's typically not responsive to fluid and requires vasopressors to maintain a map of at least greater than 65 millimeters of mercury. You're also, based on current definitions from the Septic 3 paper in 2015, likely to come across a lactate of greater than 2 millimoles per litre. The issue that we've got is that there's been a number of screening tools that have been suggested in the literature, but in validation of these tools, none of them have been particularly found to be both sensitive or specific enough to be reliable. Having said that, the issue that we've got in the pre-hospital setting is some of these tools don't really work because we don't have access to blood results. So one that is useful in the pre-hospital setting is the Quick SOFA tool, or the Quick Systemic Organ Failure Assessment tool. So if you have a patient that we suspect has an infective history and then has any two of the following, which is an altered GCS by a loss of 1 or more points, a respiratory rate greater than 22, or a blood pressure less than 100 systolic, then there's a significant risk of sepsis. But to add to that, we may also want to look at things like urine output, where if they're urinating less than 0.5 of a mil per kilogram per hour, or they haven't had any urine output for 18 hours, that's suggestive of significant organ dysfunction, especially renal failure, and in the context of a patient who could potentially have an infection, is strongly associated with septic shock. About why lactate is controversial, since we've mentioned anaerobic metabolism and lactate in the diagnostic process. So lactate was previously sold as a treatment goal, where the previous aim was to reduce the lactate number itself, and this is kind of referred to as lactate clearance. You know, if lactate comes up as part of the septic process, if our treatment is working, then lactate should go down. So the goal is to reduce the lactate number itself. Now, at the moment, there's some controversy kind of around the biochemistry behind lactate, with Marek and Bellomo's paper in 2013 arguing that lactate actually consumes more hydrogen ions than it produces, and that it actually can't really result in an acidosis, which means that lactic acidosis itself is a condition that doesn't exist. Now, that's a pretty extreme view, considering that really questions everything that's been taught for the last 100 or so years about what we understand about lactic anaerobic metabolism and lactate. But it appears that the general consensus now is to use lactate as a marker for how unwell the patient is, but not as a target for therapy. There's also some thought that lactate may actually be quite protective, and that it actually provides fuel for the myocardium, for example, in a hypoperfused state, and that even the administration of adrenaline or the release of adrenaline endogenously can also cause an increased lactate. So how do we know that the lactate that we're getting in a blood sample is actually as a result of anaerobic metabolism? So do you get that? Eddie here is a little bit confused. I am too. This is an area that's obviously undergoing some significant research at the moment. So, the management of sepsis is quite complex, but when we break it down to its simple forms, we want to maintain oxygenation with high flow oxygen, and we want to keep the SATs as high as we can, above 92%. We want to consider early intubation and ventilation, because this allows us to control oxygenation and also prevents fatigue of respiratory muscles, which can impair ventilation and cause hypercapnia. Obviously, while sepsis can have a respiratory origin, regardless of the cause of infection, patients with severe sepsis and septic shock can often have an increased respiratory rate, and that can become fatiguing in time and result in hypoventilation. We want to maintain hemodynamic support, and to do that, we want to make sure we're giving generous volume replacement, and we want to consider some balanced crystalloids. There's some recent evidence in the last couple of years, especially like the SMART trial that came out and showed that balanced crystalloids in about every 112 patients or so can reduce the number of acute kidney injuries, reduce the need for dialysis, and reduce the amount of deaths when you compare it to normal saline. And we want to consider a volume of anywhere from 10 to 30 milliliters per kilogram. Assuming that volume replacement itself doesn't correct the hypoperfusion and the hypotension, we would need to move to some vasopressors. Now, there's lots of different options here. The ones that I'm going to discuss are ones that you'd most likely come across in an ambulance service. The first of which, and the most common one, is always going to be an adrenaline infusion, where you would look at 1 microgram per milliliter an infusion rate titrated to the effect that you're trying to get, which would be a stable blood pressure and probably an improved GCS as well. And you can achieve this with the regular infusion, or by also administering 50 microgram or up to 50 microgram boluses as required. You can also commence a noradrenaline infusion if you've got access to a pump, where you'd start at maybe 400 micrograms an hour until it's effective, and then you'll down titrate, and you can maintain the infusion anywhere from 0.05 to 1 microgram per kilogram per minute. Obviously, fluid replacement and vasopressors help with the issue of hypoperfusion, but it doesn't address the underlying cause, which is obviously going to be the infection. So in bacterial sepsis, early antibiotics are imperative. This has to be within 6 hours to see some considerable mortality benefits. Obviously, this can be quite tricky in the pre-hospital field to exactly establish when the patient's infective history started, but it's a pretty important bit of information to get. If your service provides for it, consider some pre-hospital broad-spectrum antibiotics, such as ceftriaxone or benzylpenicillin. In South Australia, we use benzylpenicillin in the pre-hospital setting if we suspect a patient has meningococcal septicemia, but it's not really used for anything outside of that specific pathology. We also need to be mindful, though, that if we are going to administer pre-hospital antibiotics, that the hospital will need to draw cultures to identify the specific cause or the specific infective agent, and to do that so that they can tailor treatment specifically to that bacteria depending on what it's sensitive to. And the antibiotics that we can administer in the pre-hospital setting can interfere with that process. So this would perhaps be something that you consider if you were much further away from definitive care. Speaking of which, we need to transport to definitive care with an earlier notification. We need to make sure we go to a facility with an intensive care unit that can look after this patient. They can manage their ventilation, they can manage their inotrope needs, and also have access to all of the pathology and assessment skills that they need. Let's move on to anaphylaxis now. Epidemiology of anaphylaxis is an interesting one. It's not very easy to establish, and because data is quite sparse around the world, and it's also not very accurate, which really makes comparing morbidity statistics around the world quite complex. What we do know is that the international lifetime prevalence appears to be about 0.5 to 2% of the population. Allergy in Australia, allergy itself, by the way, which is obviously a spectrum of mild reaction to anaphylactic reaction, is very common in Australia. So about 1 in 3 people will develop allergies at some point in their lifetime. There's an increasing incidence of anaphylaxis in Australia, and admissions have doubled from 1994 to 2004, from just over 4 patients per 100,000 to 10 per 100,000. But we're also seeing the prevalence in school-aged children increasing from 0.98% in 2009 to 1.38% in 2014. And with that, we're also seeing more activations of adrenaline auto-injectors in this time as well. But this data may not be because the actual frequency of these events are increasing, but because the data collection is better, and also because diagnosis is better as well. Despite this supposed increase in incidence, the actual amount of death from anaphylactic shock is quite rare, and between 1997 and 2005 in Australia there were only about 112 identified deaths. The most common triggers are medications, food, and insect venom. Pathophysiology of anaphylaxis. Anaphylaxis is an immunoglobulin E mediated immune response to an antigen. IgE is an antibody that is formed in response to exposure by the body to antigens or a specific allergen, and IgE is found on the surface of mast cells and basophils. The antigen-antibody reaction on mast cells and basophils causes the release or the degranulation of these cells, which causes the release of histamine, heparin, tryptase, and chymase, amongst others. Now, mast cells are found in the connective tissue, while basophils are a type of white blood cell that is found circulating in the blood. They are similar cells, but they are not the same cell in a different location. We also see the release of histamine-releasing factor, platelet-activating factor, tumor necrosis factor, interleukins, leukotrienes, interferon, and prostaglandins, amongst other mediators. We'll focus on histamine because histamine has a significant role in anaphylaxis, and you'll also notice that anaphylaxis has a similar pathway to sepsis in terms of the dysregulated host response, but the underlying trigger and cause is different. So histamine causes a number of issues in this dysregulated host response, one of which is bronchoconstriction. It does this by binding to the bronchiole smooth muscle histamine 1 receptor, which activates the G protein messenger pathway. And this further activates phospholipase C, which releases calcium from the endoplasmic reticulum. The increased free intracellular calcium is then available for the actin-myosin crossbridge formation, and this causes bronchoconstriction. Meanwhile, in the vascular system, histamine causes the opposite. It causes vasodilation. And it's thought to do this by activating the CAMP pathway, the cyclic adenosine monophosphate pathway on the vascular smooth muscle wall, as well as activating the cyclic GMP pathway by activating endothelial nitric oxide synthase, which increases the amount of nitric oxide being produced. And nitric oxide itself then activates cyclic GMP, which causes calcium reuptake, meaning that less calcium is available within the cell for sliding filament muscle contraction, and that results in vasodilation. As we mentioned before, other mediators are also implicated in the modulation of this response, but we'll focus on histamine due to its prevalence. Because those other mediators are involved, sometimes we can see a delayed response, and this is called a biphasic reaction. Around 6% of patients with an anaphylactic reaction will develop symptoms after they initially subside, but will reoccur anywhere from 1 to 8 or even up to 72 hours later without subsequent re-exposure to the allergen. And this is why it's often wise to transport patients with anaphylaxis to hospital for observation. Let's move to the assessment. Now we've got a really good image on the right here which looks at the various impacts of anaphylaxis on the body systems and the symptoms that they can display, and also mentions the inflammatory mediators that are usually responsible for those particular symptoms. As you can see, histamine is involved in all of them. So anaphylaxis is really described as a severe multi-system immune response that occurs rapidly and often has life-threatening results. There are three main threats to life, which are the bronchospasm and mucus production. And to assess for this, we're going to need to listen to the chest for any wheezes. We're going to monitor the rest rate to see if anyone is tachypneic and struggling to breathe, or even at the point where their breathing is so bad and they're so fatigued that they may become hyperventilatory as well. We want to monitor their oxygen saturations to make sure that their oxygenation is effective, and we also want to monitor the end-tidal CO2, mainly as a reason to be able to keep an eye on their respiratory rate easier, but also can show any signs of any kind of acid-base disturbances underneath. With regards to the vasodilation, we're going to want to monitor their blood pressure very often, keep an eye on that. We're going to want to monitor their heart rate to make sure they're not too tachycardic, and we want to keep an eye on their ECG as well. The other area was angioedema of the face, neck and upper airway. Obviously this one is more based on our eyes, so we want to observe the face and the eyes for any signs of edema. There's a good picture here from Holman 2010 under a Creative Commons license, which shows a child with severe angioedema of the eyes, and they can't even open their eyes, the swelling is that severe. We want to listen to the trachea, where we want to hear for any stridor or difficulty breathing. We want to ask the patient to swallow and see if they have any difficulty swallowing, which can be indicative of tongue swelling. We also want to look for tactile phragmitis, where you can place your fingers on the patient's neck around their hyoid bone, and whilst they breathe you can feel some popping and cracking underneath there, which is suggestive of fluid. We also want to look for things like urticaria and hives on the skin, and we can also see gastrointestinal symptoms as well. Of anaphylaxis is a tricky one, where the first line agent and the first thing that we want to do in a patient whom we suspect is having a severe anaphylactic reaction is the administration of intramuscular adrenaline. And this is usually at a dosage of 10 micrograms per kilogram up to a total dose of 500 mics. This can be repeated every 5 minutes if it's required, and adrenaline is good because it helps reverse the bronchospasm and it helps reduce vasodilation, but it also helps settle those pesky mast cells down. So we see less degranulation of histamine, so we don't want to be too hesitant to give adrenaline. In anaphylaxis, this drug isn't reserved only for the most severe and life-threatening cases, unlike asthma. This is a drug that will make significant improvements in your patient. We want to support oxygenation with supplemental oxygen as required, or if the patient is hypoventilatory, we want to consider our intermittent positive ventilation, and we want to consider PEEP as our positive end expiratory pressure valves as well, because there is a loss of auto-PEEP with severe bronchospasm. We can address the bronchospasm with adrenaline, it does a good job at that, but we can also be more specific and administer salbutamol and ipratropium bromide nebs. They work really well together because one activates cyclic AMP and the other blocks cyclic GMP, and that causes bronchodilation, which and also helps in the reduction of mucus secretion. We want to obtain IV access and give generous fluids again at 10 to 30 milliliters per kilogram. But if the blood pressure is refractive to fluid, again, we want to go down the vasopressor infusion pathway. And that's similar to sepsis management if we look at the dosage regime there. We also want to consider early steroid administration. This isn't a first line thing that we need to jump on to, but it's thought that steroids can help prevent or shorten protracted reactions, but this hasn't got great evidence surrounding it. An example of this would be about 200 or 250 milligrams of hydrocortisone IV. You want to consider oral antihistamines if they're tolerated. These are especially great for more mild to moderate reactions, but if a patient can tolerate taking them orally in more severe reactions, it's probably a good idea as well. They block histamine receptors, which helps minimize systemic responses to histamine. An example of this would be 180 milligrams of oral fexofenadine. And we also want to consider antiemetics if the patient is vomiting, not only for patient comfort, but also to protect their airway in a patient with angioedema and also to help reduce plasma loss. So that was some distributive shock pathologies. Let's look at obstructive shock. Obstructive shock is the least common form of shock in only around 2% of shock patients. There's a number of causes such as tension pneumothorax, but also massive pulmonary embolism and cardiac tamponade, for example. We'll only focus on tension pneumothorax because it's one of the only mechanisms that paramedics can actually manage. The frequency of tension pneumothorax is not very well known, but we know that about 5% of traumatic cardiac arrest patients will have a tension. Tension pneumos are mostly associated with both penetrating and blunt thoracic trauma, but they can also occur spontaneously in an atraumatic presentation in about 7 out of every 100,000 males or 1 in every 100,000 females in the USA. So, a tension pneumothorax is a type of a primary pneumothorax, which means it doesn't have any underlying lung pathology, where there's a volume of air that is stuck under pressure due to injured tissue forming a one-way valve, which allows air into but not out of the pleural space surrounding the lungs. This volume of air increases with each inhalation, and that causes increased intrapleural pressure, which subsequently causes the lung to partially or completely collapse, which eventually impacts on the lung's ability to ventilate. As the pneumothorax continues to worsen, we start to see an increase in intrathoracic pressure as well, which impedes on the structure of the great vessels in the heart itself, which causes an obstructive shock state by impeding venous return to the heart because it compresses the low pressure vena cava. It also reduces preload, which in turn reduces cardiac output. Severely increased intrathoracic pressure also increases afterload, which means the left ventricle has a greater force to eject blood against, and that also reduces cardiac output, which results in hypotension if it's uncorrected. And there's a great video here showing a tension pneumothorax from within the thoracic cavity, and we're going to use some of these. So have a look at this image and see what you can identify in terms of landmarks and anatomy with on the screen here. If we move here, I've done some excellent drawing. You can see the bottom right is the lung, which is deflated. We have the chest wall at the background of the image where you can clearly see the ribs. And the white tip at the top there is the needle chest decompression cannula that's been punctured through the chest wall. So this lung is actually in the process of re-expanding, and you'll be able to see that in the video that I have linked before. So how are we going to assess for a tension pneumo? Well, we need to consider a tension pneumothorax in all traumatic cardiac arrests, in any patients with chest trauma or major or multi-trauma, or we also want to consider them in the acutely short of breath patient who is tall, skinny or marfanoid, especially if they're a male, even if it's atraumatic. Connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome can experience spontaneous atraumatic pneumothoraces. Symptoms of attention pneumothorax include absent or dull lung sides on the injured or affected side. We can see some jugular venous distension. We can see decreased SATs, tachycardia, tachypnea, hypotension, especially in the absence of any other obvious cause of hypotension. We can have a diminished or absent radial pulse, an altered conscious state. One of the signs that's often touted is tracheal deviation to the contralateral side of the attention pneumothorax. This is a rare and very late sign. It's also really, really difficult to observe in a patient without having their chest open. It's important to note as well that not all of these signs and symptoms will be present in a hypovolemic patient. So how are we going to manage it? Any cause of obstructive shock needs urgent correction. And for example, there have been cases of massive pulmonary embolism being diagnosed in the pre-hospital setting with ultrasound and then being corrected by thrombolysis, but this isn't yet routine paramedic practice. So for attention pneumothorax, the first line intervention is a needle chest decompression. We can do that in two spaces. The fourth intercostal space at the mid-axillary line is the preferred site, as there's less tissue to penetrate and less likely to cause damage to the underlying structures. It's also more successful and works around body armor. The second intercostal space at the mid-clavicular line is the classic site, and that's the second site of preference. It can be harder to accurately locate, and there is a risk of striking the great vessels underneath. Some patients can have quite thick pectoral tissue to penetrate, but it shouldn't be a problem with the right equipment. Finger thoracostomy is the gold standard in the pre-hospital management. It's done again in the triangle of safety at the fourth intercostal space at the mid-axillary line, where you need to make an incision over the rib down to the bone, and then you roll your spreaders over the rib into the intercostal space and widen and dilate the incision. After that, you pull the spreaders out and insert your finger and sweep. You could potentially feel the lung reinflate, and you can also see evacuation of any blood or empyema that may be causing the tension if it's not air. Consider giving some fluid to aid in venous return. And if a patient is apneic, minimize ventilation until it's fixed. Remember that with every ventilation, the tension is likely to worsen. So if you're like Andy Dwyer here and you suddenly go, "Ooh, that's attention pneumothorax," jump on it quickly and manage it straight away. Cardiogenic shock. Epidemiology of that is that it's declining in the Western world, but it still occurs in just under 10% of STEMI patients, just under 5% of non-STEMI patients, and there's about 40 to 50,000 cases annually in the United States. Risk factors include being old, having previous left ventricular injury or infarct, female gender, and having diabetes. So the pathophysiology for cardiogenic shock really depends on the underlying cause of shock, but I'll focus on dysrhythmias because they are issues that we can manage as intensive care paramedics. Some of the other issues like left ventricular dysfunction and valvular emergencies are not particularly easy to manage as a paramedic. So first, we'll look at some dysrhythmias. Dysrhythmias can cause profound shock, and this is both brady and tachycardias. Although, according to EM-CRIT, where we're getting this image on the right here, we need to challenge our thinking about these rhythms. A lot of people worry about moderate tachycardias, and they rightly worry about severe tachycardia, but we kind of underestimate the severity of bradycardias. Dysrhythmias cause profound shock because of decreased cardiac output, and that leads to hypotension and again, and tissue hypoxia. In both tachy and brady rhythms, preload is lost and stroke volume can only compensate so far. While we can manage the symptoms, it can be really difficult to treat the underlying cause of the dysrhythmia in the pre-hospital setting. Bradycardias, there's a number of things that we need to make note of. As I said, that we can underestimate the severity of a bradycardia, especially if they have a normal blood pressure. And as you can see on the next graph on the right, there's three potential responses to a bradycardia, where you can have a vasoconstrictive response and you get your systemic vascular resistance increase, but your blood pressure stays about the same. You can get a bradycardia without a vasoconstrictor response where your blood pressure is dropped, or you can get a bradycardia with a massive sympathetic response which causes hypertension. It's quite rare, but as you can see in all three, cardiac output is still poor. So even if there's a compensatory increase in systemic vascular resistance, the cardiac output and hence oxygen supply is still insufficient due to a low heart rate. So even if we consider the heart rate decreasing by a factor of 2, the stroke volume can't possibly double, which means increasingly severe bradycardia should really be a significant concern for cardiogenic shock. So the causes of bradycardia include but aren't limited to medications such as beta blockers or calcium channel blockers, cholinergic medications, digoxin, propofol, and alpha blockers like prazosin. You can see bradycardias from an MI, especially if there's damage to the sinoatrial or atrioventricular nodes, or metabolic causes as well, like hyperkalemia or hypoglycemia or severe hypoxia, hypercapnia or acidemia. And also, you can see bradycardia in patients who have a failed permanent pacemaker. Well, we're going to do our routine observations: heart rate, blood pressure, respiratory rate, capillary refills, SATs, end-tidal CO2, temperature, blood sugar. Capillary refill can still be delayed if the patient is normotensive. So that's a good way of demonstrating if the patient has impaired perfusion despite having a normal blood pressure. A patient is considered symptomatic of blood pressure if they have any of the following: chest pain and discomfort, shortness of breath, altered GCS, they're complaining of feeling dizzy or lightheaded, they might have acute pulmonary edema due to pulmonary congestion, and obviously if they're hypotensive or have a delayed capillary refill in the context of a bradycardia. But if they don't have any of those and they're bradycardic, then they're considered asymptomatic. We want to obtain a 12-lead ECG to help differentiate the underlying cause and also to assist in treatment planning. We also want to really probe into the patient's history. Do they have a history of renal failure? Do they have a history of diabetes? Renal failure can cause hyperkalemia or other electrolyte disturbances. Hypoglycemia can cause bradycardia. Do they have pre-existing heart disease? Increased risk of having had an MI, or maybe they already have a history of blocks or dysrhythmias. Have they had any medication changes? Have we added any new cardiac drugs or increased their dosages? Have they been having any falls lately? Maybe the bradycardia has been paroxysmal and they might have had, it might be the cause of falls, and give you an indication of how long the patient's been unwell for. Or maybe they've had vomiting and diarrhea, which can also cause electrolyte derangement. So, management of bradycardia. So if the patient is symptomatic, we want to treat. There is a risk of torsades if we don't manage the heart rate. It's because bradycardia causes a prolonged QT interval, and that puts the patient at risk of developing torsades because it's a pause-dependent rhythm. And there are medical and electrical pathways which we can more or less prepare at the same time and use at the same time to manage the bradycardia. So we want to get IV access, we want to apply anteroposterior pads because air isn't a good conductor of electricity, so we want to avoid the lungs. And we want to correct any other derangements that could be causing the bradycardia, like their BGL or their oxygenation. If we think that there's a reasonable chance that the patient could be hyperkalemic, maybe we can consider some salbutamol nebs, as this helps move potassium back into the cells. But this can be seen on the ECG with some peak T waves, a wide QRS, and a history that fits, like renal failure or recent loss of plasma or electrolytes. First line management is IV atropine, but this might not always work because of, for example, if you're looking at an AV block, there's minimal vagal tone in the AV node. Most of the vagal tone is found in the sinoatrial node. Some patients just don't respond to it. If it does work, it's usually transient and the problem isn't fixed. And it's also important to note not to give it to heart transplant patients because it can cause blocks or asystole. Atropine is a muscarinic 2 receptor antagonist, meaning that it blocks the parasympathetic nervous system. Adrenaline infusion may be required. Adrenaline is a sympathomimetic, and you'll get increased heart rate, increased force of contraction and excitability, and you'll also get increased peripheral vascular resistance. It's usually pretty effective for the management of bradycardia, and some people suggest going straight to adrenaline infusion in the unstable brady patient as opposed to starting with atropine. Some patients will need transcutaneous pacing, where a small amount of a direct current countershock, compared of course to defibrillation, a small amount, acts like a pacemaker but through the chest wall. This is probably a good choice in a patient who's not responding to adrenaline or who is peri-arrest. In these patients, sedation would be nice. It's obviously a painful procedure, but it's not always safe because many sedative medications can drop your cardiac output or vascular resistance, and that can potentially chip your patient over the edge. Tachycardias, the pathophysiology, much like a bradycardia, tachycardias can cause a circulatory insufficiency. This is usually seen around 150 beats a minute or more, but can occur at slower rates depending on the patient. Increased heart rate leads to decreased ventricular filling time, and that means we have a loss of preload, back to the Frank-Starling law, and we also have a decreased stroke volume, which results in decreased output, which results in shock. The type of tachycardia is suggestive of the underlying cause, and they have different ways of being treated. So we need to identify the type of rhythm to point to potential causes and treatments. Sinus tachy is the most common tachydysrhythmia, but it's not usually a problem in and of itself, but usually a symptom of something else. There are heaps of causes of tachycardia, and these is not an exhaustive list, but we can have hypovolemia and hypoxia or other shock states, fever, electrolyte disturbances, reentrant pathways, medications, MI or underlying cardiac pathology, and many, many others. Again, like our bradycardias, do routine observations. We want to do our 12-lead ECG, and we want to make sure our pads are on. And then we need to differentiate if the patient is stable or not. A patient would be considered stable if they, had a good blood pressure and didn't have any of like an altered GCS or chest pain, for example. If the ECG is fast and wide and they're not conscious, and not breathing normally, we need to shock as soon as possible before performing any further diagnostics. We need to consider if it's a narrow complex or a broad complex tachycardia, and there's a good little diagram or flow chart here on the right to figure out what you could be looking at. In patients that have a tachycardia, especially at a rate where the ventricular activity can obscure the atrial activity, consider doing a Lewis lead, which is this image in the top of the screen. Thanks to Watford and EM Crit there. That can actually help give you a great view of atrial activity, and this can be useful in determining the rhythm. I use this quite often on the road, and place the electrodes as shown in that diagram and monitor in lead 1. We want to get IV access again as proximal as large as possible, because some of the medications that we might administer have a short half-life and they need to reach the heart quickly, and an example of that would be adenosine. So the management. If they're unstable, we want to cardiovert as soon as possible. And there's a good little flowchart there as well to help you kind of decide what we need to do if it's a sinus rhythm or if it's not a sinus rhythm and the patient is unstable. Again, it's important to remember this isn't an exhaustive list of potential tachydysrhythmias and how to manage them. These are ones that you're probably more likely to come across as an intensive care paramedic. Management of tachycardias can be complex, and some patients have time to try less invasive procedures and others most certainly don't, and this is up to your judgment on the day. So if we consider SVT, maybe consider a modified vagal maneuver, then IV adenosine, and then cardioversion if it's refractory. Vagal maneuvers are good because they're not invasive. However, if they don't work, we need to move along that treatment pathway, and we need to prepare for that. Adenosine is a Vaughan-Williams class 5 drug. It hits the adenosine 1 receptor and agonizes it. It causes a potassium influx and hyperpolarizes the cell. It's very active at the AV node where it temporarily blocks conduction but has a very short half-life as it's metabolized in the blood. If we got a patient with conscious VT, let's consider cardioverting as soon as possible because it's a very unstable rhythm. Otherwise, you could consider an amiodarone infusion. It's a Vaughan-Williams class 3 antiarrhythmic, works by blocking potassium efflux from the cardiac pacemaker cells and prolongs phase 3 of the action potential, which causes a longer absolute refractory period. It makes it harder as a result for an action potential to trigger depolarization. It's important to note, though, that amiodarone is a really messy drug, and it interferes with the metabolism of other medications and has a really long half-life, anywhere up to 100 days, and it's got a wide volume of distribution, so its use can cause problems down the line. If we have a patient, for example, with unstable atrial fibrillation who has a rapid ventricular response, most of the time this will be fairly well tolerated, but you could consider a fluid bolus. Otherwise, if they're severely decompensated, you'd probably need to cardiovert this as well. It's just important to note that you need to be careful of a patient with Wolff-Parkinson-White and atrial fibrillation or flutter. Wolff-Parkinson-White patients have pre-excitation due to an accessory pathway, and about 1 in 5 can develop atrial fibrillation as well. AFib and Wolff-Parkinson-White are seen together when you see ventricular rates over 200. They often have an irregular rhythm, a normal axis, and a wide QRS that often changes morphology. In this case, really cardioversion is the only possible solution, because if we administer any AV nodal blockers like adenosine or amiodarone, we can inadvertently put the patient into a degeneration of ventricular fibrillation or ventricular tachycardia, so we can potentially cause them to arrest, and that's obviously not ideal. So that ceases my presentation with regards to shock. Like I said, it was a cursory overview of a number of different pathologies, but hopefully some stuff that you'll see on the road and stuff that I have learnt from doing research for this. And here is my reference list. Let us know if you've got any feedback. Thanks.